Hey everyone, welcome to the TED Win Inclusivity Conference. We're excited for you to be joining us for today's presentation. I'm Tina.
And I'm Gina.
I'm Heather. We are your hosts for this week's conference.
And we wanted to give a big shout out to our gold sponsors, Alsana, Center for Discovery, EDRE Pro, and Simple Practice. Your support means a lot.
Stay tuned for the Q&A in your Facebook group or through the YouTube if you'd rather watch it later.
Hello, my name is Nikki, and I'm presenting today with Lauren, and I am a registered dietitian and certified diabetes care and education specialist, and we are going to be presenting on diabetes burnout, why it happens, how to prevent it, and how to pivot. And I'm going to let Lauren introduce herself.
I'm Lauren Newman. I'm a registered dietitian in Houston, Texas. I have a private practice here, and I specialize in working with people who have diabetes and have eating disorders as well. So
that's right. Well, and Lauren and I are actually both in Houston. I forgot to mention that, and we both specialize in diabetes and eating disorders.
Yeah. Awesome. So I guess the best place to start is even defining what diabetes burnout is. For those of y'all that maybe don't work specifically in diabetes care, this might not be something that you're super familiar with, but those of y'all that do work in diabetes care are super familiar with this, I'm sure. So, diabetes burnout, really what we're talking about is somebody who is just really exhausted and overwhelmed by all of the things that, they have to do in relation to their diabetes care and diabetes management. So oftentimes this presents as somebody who just has like a disregard for their blood sugar levels. They're not really checking things consistently. They seem to not be on top of a lot of their care. They might miss appointments or cancel appointments or not show up to things. There's just overall a lot of avoidance around their diabetes management and care. And so oftentimes this can be really scary because we know that there's a lot of like medical complications that come with diabetes, and for dietitians as well, a lot of us, work very directly with our clients who have diabetes on how to manage their care through food, and it can feel scary to see somebody in a space where it looks like they just don't really care what's happening and they're not taking a lot of action or acting on our recommendations. And so this can be a really frustrating experience both for the patients and for the providers as well. And oftentimes what winds up happening is these are the people that get labeled as non-compliant, and they kind of fall into that category in the way that we're talking about them as providers. And so we're going to talk a little bit more in depth about like really where this is coming from, because this isn't coming from a place of non-compliance per se. So we're going to talk more about that, and then we're going to talk about how we can actually best support our patients and our clients when they're experiencing this. So I really love this Instagram post from one of our colleagues. She's talking about this idea of like the quote unquote non-compliant patient. Oftentimes in the diabetes world, when we're labeling people as non-compliant, my personal opinion, and I think Nikki shares this sentiment, is that these are the people who are just extremely burnt out. And so, this idea that our clients aren't actually non-compliant, they're fearful, they're overwhelmed, they're anxious, and like maybe traumatized and really stressed by all of this, all of their experiences with diabetes, and all of the mental space that it takes to actually manage this disease, no matter what type of diabetes you have. They're really lacking in a lot of things. And so as providers, we can better support them by meeting those needs, and, helping to fill in gaps where they might be lacking certain things. And, really, I think it's important for all of us in all aspects of where we work and who we're serving to, look beyond this idea of non-compliance. In all areas of healthcare, but especially when we're talking about diabetes, like the people that are getting this label are often the ones that are the most burnt out. And so it's helpful to think of, I know this is a big chart with a lot of words and a lot of colors, but, really I think it's helpful to talk about the way that our nervous system tries to help us regulate when we're trying to understand diabetes burnout, when we're trying to understand this idea of patients like being non-compliant or not following our recommendations, or maybe not showing back up into our offices when, things are hard. Because for most people, right, when we're feeling really competent and able to handle all of the things that are being thrown at us, we're really in this state of our nervous system being very well regulated. And that also translates to a lot of, you'll see on the right side, a lot of different responses in our body on a physiological level. And so, I think if we can all reflect on this in our own experiences in times when we're really regulated versus really stressed out, you can notice a lot of those different physical symptoms that change, and also the emotions that change. So we talk a lot about, and a lot of people are very aware of this idea of, fight or flight, where we're in our like very sympathetic nervous system, and there's some kind of like intense arousal that's making us want to run towards something and fight it, or run way far away from it. And, you can see on this chart or this diagram, all of those different emotions that kind of come along with that. But oftentimes what happens is when things get even more overstimulating and overwhelming, then we get pushed to this point of freezing. And it can lead to a lot of shutdown and all of these different emotions that are up there in that top category. And, we'll talk more about this as well, but I really think it's important to highlight all of these different physiological side effects of our nervous system getting dysregulated that are listed on the right, because as dietitians, right, we're working with people in their food and their relationship with food and their bodies. And so, when we're talking about diabetes, like, yeah, all of these emotions are going to, amp up, and they're going to feel really, our patients and our clients are going to feel super overwhelmed and super incapable of handling what's happening. And then on a physiological level, if you look at all of those side effects, their blood sugar is going to go crazy. It's going to be bouncing all over the place, which is not going to help their case at all when they're already feeling overwhelmed and burnt out. And, another way of talking about this is this idea of a window of tolerance, where, we want to be in the middle, and there are lots of things that can push us outside of that window of tolerance. And the more overwhelmed we are, and the more decisions that we have to make, and the more stressful things become, that window of tolerance just starts to shrink and shrink and shrink. And so it doesn't take very much to push you outside of that window of tolerance, which then is going to lead to all of this dysregulation physiologically and in our emotions as well, which is a huge contributor to burnout. Beyond the nervous system regulation and the physiological things that we see happening, there's also all of the psychosocial contributors to diabetes burnout. So we're going to go through a couple of them, but there's just so many factors that contribute to this, and each individual person has their own story and their own experience to what's happening. So one of the largest contributors to this is this perfectionism and really high expectations that we see in the diabetes world. So, there's a lot of attention to detail, there's a lot of numbers, and there's a lot of equations and expectation that, if you would just follow the math equation, then the blood sugar will just follow and it will be perfect and it will align. And that actually isn't the reality. And that can be so frustrating for people, especially when they're constantly hearing from providers that, well, if you just count the carbs right, or if you just dose it correctly, or follow this equation, or, your pump does the math for you and it should be fine. And what did you do wrong? It just gets turned into this blaming of the patient, or just having really, really high expectations for the like amount of time that all of these things are going to align and work the way that we intend them to, which isn't the reality for most of our patients and clients. There's also a lot of talk, specifically in the pre-diabetes or type 2 diabetes space, of like reversing diabetes and these high expectations around what like quote unquote normal or like ideal blood sugar numbers or A1C levels should be. And overall, what winds up happening is we see patients and clients who are feeling frustrated with how unpredictable their body feels compared to the promises and the expectations that they're given by providers on like how it's supposed to look and how it's supposed to be. And so it leads to them feeling like they're failing and not perfect and not right, and leads to a lot of shame. Also, something important to note on here is there's a lot of threats that get used as motivation. So, for example, with type 2 diabetes, like, get your numbers to this level or do X, Y, and Z things, or else you'll have to take insulin, or else like X, Y, and Z things will happen. If you have type 1, it's, make sure you like count all your carbs exactly, like, or else you're going to have all these complications. And I think it's not helpful for people, and also contributes to a lot of the shame that we see happening. Somewhat related, there's a lot of black and white thinking and a lot of extremes in the language that we use talking about diabetes. So, we have a good and a bad blood sugar. Well, they're actually, they're not good or bad. Maybe we can change the language that we use around them to help our patients feel less stressed out by this thinking. We test our blood sugar. Well, it's not a test. There's no right or wrong answer. It's just collecting data and collecting information and, using that to make a decision and move forward. We use the word control when we talk about diabetes management all the time. And that can, when things aren't going the way we expect them to, then it feels like it's out of control, and that's stressful, rather than, the gray area of this isn't going to be perfect all the time. And this is just going to, it's going to be somewhat unpredictable, and it's not always going to work the way we want it to. There's a lot of like colors on different CGMs or pumps. If your blood sugar comes up in a higher number range, it turns red, and that can feel really alarming and, just really activate somebody in that way. And overall, all of this language and all of these like extreme ways of thinking about things is typically encouraged by healthcare providers. And so it can be really validating and really helpful for clients to start moving away from these like black and white ways of talking about how we manage this disease, no matter what type it is. There's also the aspect of decision fatigue. There's not great studies on this. There's so many different studies and really not concrete information about the exact number of decisions because it's just so hard to measure. But different studies show somewhere between an extra 180 to 400 diabetes-related decisions per day that people with diabetes are having to make to manage their disease. That's a lot. And not only is that a lot and taking up a lot of brain space, most of these decisions involve, especially with type 1, involve some kind of insulin dosing or, thinking about what they're going to do to keep their body safe. And it's important to highlight that these really are life and death decisions sometimes, which is pretty extreme and intense for somebody to have to deal with, even if not every single one of them is an actual life or death situation. When we have clients who have had, some kind of extreme situation with their care in the past, every single decision starts to feel like it's going to be a life or death thing, and it's going to spiral into that place. And so it's exhausting, and it also really disconnects our patients and our clients from important moments in their lives, which is something that really disrupts their quality of life as well. on top of all of this, there's a lot of major life events that can contribute to somebody feeling more burnt out than usual or just more overwhelmed than usual. We have people moving from different life stages, and those big changes can just add exponential amounts of new stress and anxiety and tasks to deal with and decisions to make. There's also, especially with type 1, when we see people moving from pediatric care into adult care, that's a time where burnout tends to pop up as well, because, they are getting different care than they've received before. A pediatric endocrinology clinic functions very differently than an adult clinic for a lot of people, and it just starts to look different. But any of these major life events or life changes can be the catalyst for an episode of burnout. Identity is something to consider as well. A lot of people with diabetes, the identity can be either like a very positive thing or a very negative thing in their life. For some people, it's, especially with type 1, I see this in a lot of my clients that, they've had diabetes for a really long time if they were diagnosed when they were young. And so it starts to feel like this is all that I am. This is all that's important to me. This is how everybody knows me and has known me my entire life. It, is like a personality trait rather than just, a healthcare or an aspect of their health. And that can be positive for them in some ways or really negative. Some people feel really ashamed by the fact that they have diabetes and don't want other people to know about it, or they, fear judgment from others about it. And so, they keep it very hidden. And so they're maybe not reaching out to as many people about it, or they're just having a lot of distress around the fact that they have been diagnosed with diabetes. And that distress, even in and of itself, can be a catalyst for burnout. So can, not having other people around you that understand what's happening, because you're, not wanting to identify as having diabetes, and then you don't have a support system around you. There's a lot of desire in the community to be normal, and I just wish I were normal and I didn't have this, and getting very caught up in that can be distressing. And oftentimes people who have diabetes and have been diagnosed with it aren't given an adequate space to grieve their diagnosis or their changing body or whatever it is. And that is a big deal. That's a really big deal. Oftentimes that space isn't given because there's shame and guilt around having been diagnosed with diabetes, and so they're not even talking about it and in denial about it, or something like that is happening. Or maybe they were diagnosed with type 1 when they were very young, and so they've never really known any other way, and so there's no room for that in that conversation. And overall, I think the biggest thing that I see around identity and our patients and clients with type 2 is this fear of did I cause this, or did I do something wrong? And that starts to really wear on people. I mentioned a little bit about support system, but the lack of support system is a really big deal. We know that connection is an important part of health for everybody. And when you have some kind of chronic illness of any kind, really having an adequate system and community of people to support you through that is important. So, people who don't have an adequate support system might have difficulty finding validation. Maybe they have people that are in their life, but, they get advice around things from these people and they hear it as criticism, just the way in which it's communicated. And, also support system isn't just our family and our friends. It's also our dietitians and our therapists and our CDEs and our endos and everybody. And so, sometimes medical appointments and our doctor and medical support that we get with diabetes is very short appointments. A lot of times my clients talk about like not even wanting to go to the doctor because it's just, I get my grade of my A1C and then I leave and there's like nothing helpful there. Sometimes people are frustrated with the medical system with like, lack of creativity in medical interventions, like trying something and feeling like it's not working and feeling unheard. And so not getting the support that they need from their medical providers. Oftentimes the complications that we discuss around diabetes, a diagnosis, there's like a whole list of things that we give our patients and our clients. And as a dietitian, if you've ever done like a new diagnosis education, you know how this looks. And there's the whole list of things. And it's make sure you get your feet checked and make sure, you see the eye doctor and make sure you go to the endo every 3 to 6 months and make sure all the things, right? But nowhere in there does it include any information about the potential for like mental health complications or eating disorders, or make sure you see a therapist, or here's a referral to a therapist that, understands this. That's not something that's there. And then, a bigger issue in and of itself is that when we're talking about a support system, is that a lot of people don't even have access to care at all. Our, healthcare system is really challenging for a lot of people. So even getting access to doctors or a dietitian or an endo, or like even like an endo, there's a lot of people that have a primary care managing their diabetes. And then diabetes medications and technologies are super expensive. If you're not aware of how expensive insulin is, maybe you should pause this and go look that up and do a little bit of advocacy work around that with us. But really, like, these medications are very, very expensive, and the insurance companies put so many hoops to jump through for everything that, sometimes the support system, in terms of medical providers or specialists or technology or pumps or whatever it is, there's just too many hoops to jump through, and people can't get the support that they actually need. Something else for us all to be aware of as providers is the way that stigma affects the people that we work with. And so, this is happening both in our offices and in our medical system and outside of it as well. And it's overall just incredibly distressing for our clients, and it really winds up affecting not only how they feel about themselves, but also the care that they receive. So ultimately, all of this has the potential for some serious burnout, or really contributing to that distress that they're feeling around their diabetes care. So, for example, weight stigma, it shows up very strong in diabetes care. So in our offices and in our medical system, we have clients that are getting messages that are blaming their bodies or blaming their weight, or blaming their weight for complications or any kind of struggle that they're experiencing. We have a lot of care recommendations that are made entirely based on what we think it's going to do to the size of somebody's body. As dietitians, especially as dietitians, but also most medical providers, were trained in school to focus on weight loss as a primary goal for diabetes management, even when that's not necessarily going to be the most helpful thing for somebody. And then outside of our offices and in the rest of society, there's a ton of stigma and misconception about all different kinds of diabetes. And so much of it is rooted in weight stigma and fat phobia. And so our clients are exposed to this every day. They're exposed to it in our offices. They're exposed to it in their doctor's offices, in the medical system, in, their friends and their family and the lives around them. And ultimately, it's really just shrinking that window of tolerance and making them less likely to trust us as providers and actually show up for appointments and get the care that they really need. And so it's contributing to burnout in a variety of different ways, right? It's really lowering that window of tolerance and making it that much harder for them to self-regulate and keep themselves in check around that and keep doing what they need to do. And then when they're getting these messages from providers as well, then if they're not showing up for appointments, then we can't help them. And we can't, even with the best intentions, like we can't get through to them to get them the support and the care that they need. There's also, many ways in which racism or other social stigmas show up in our society, kind of make their way into diabetes care as well. And this winds up affecting clients on both an emotional and mental level, and then on a physiological level as well, and a biological level. So there's actually a woman on Instagram in the diabetes community who I follow and I really love. Her Instagram name is Taylor Beddick. She's a Black woman with type 1 diabetes, and she wrote an incredible post back in, I think, June, sometime over the summer, highlighting so many examples of medical racism that she's experienced as a Black woman with diabetes. And I highly recommend looking up that post. I think the screen or the slide on the front says overheard while being Black and diabetic or something like that. And it's fabulous. Not fabulous because none of those things are great, but she has a really wonderful list of different ways in which this has affected her over the years. And the comments are an equally powerful discussion to take part in or to read if you're curious about how this shows up. And then, in addition to medical racism, we also have to account for all the ways in which our clients are experiencing racism overall and in their lives and in our society, and the way in which that, also might be pushing people outside of their window of tolerance, or really shrinking that window of tolerance, especially right now in our current political climate. And so even acknowledging this for clients and explaining to them how, on a biological level, this also makes sense why their diabetes management is feeling so much more frustrating, right? Like if they're that much more stressed, then they're that much more cortisol and that much more insulin resistance, and everything is feeling unmanageable. Well, yeah, of course that makes sense. And so explaining that to them and really validating that for them can be a really helpful tool in helping them feel less overwhelmed by all of it and less burnt out. And then, we have ableism as well. This shows up in so many ways for our clients with diabetes. There are many ways in which people with diabetes feel limited or restricted from engaging with certain parts of their lives in certain parts of the world because of their chronic illness or because of complications from diabetes. There's also, a lot of frequent discussion around in the diabetes community around the idea of do you define yourself as disabled or not? Because so many people feel like, well, it's more invisible, you can't really see it unless you see somebody's insulin pump or their CGM or something. You don't really know that they have diabetes. And so there's that piece of it as well, that they're living this life where things are, they are affected by ableism in our society, but also not even identified as being disabled because you can't see it. So that also kind of ties back into that identity piece of things, but it can be very distressing. So, overall, all of these things just add to the level of emotional distress and feelings of being super overwhelmed by everything that's going on, and it's just adding one thing on top of another that is exactly how that window of tolerance shrinks and people wind up very burnt out.
Alrighty, so I'm gonna take over talking about understanding the emotional fuel. And as dietitians, healthcare professionals, how do we navigate that? Because the emotion in the room can sometimes feel overwhelming to manage. And Lauren, can you advance the slide for me? Thank you. All right, so first and foremost, it is so important that we kind of have this framework in our mind where our truth is that there is no such thing as an unmotivated patient who doesn't get it. And I can't stress just how important that is. This is inspired by Dr. Adele LaFrance, creator of emotion-focused family therapy. And actually what we're part of what we're going to be presenting in the next few slides is based on that. It's called emotion-focused healthcare. And yeah, so it's coming from this place of there is no such thing as someone who's unmotivated or who doesn't get it. There's just some emotion blocks in the way. And another thing that's really important to keep in mind is that everyone is doing the best that they can with the knowledge, resources, and capacities currently available to them. So it's important that we dig 3 layers deep underneath what we're seeing presented to us in the room. So I think that this is a really helpful slide for conceptualizing motivation. So this is based on, Prochaska and DiClemente's stages of change. And it's not that we want to change that. I think that it's, we just adding these emotion layers and emotional self-efficacy layers can be really helpful for us understanding motivation better. So again, getting to that place of, all right, there's no such thing as someone who's unmotivated, right? Because inherently, from a humanistic view, we all want to do good and we all want to be good. And that is true at our deepest core, at the deepest core of our being. And so if that is true, then what is it that gets in the way of us doing what we want to do? And the 2 emotions that show up most often that inhibit motivation or inhibit action are fear and shame. And oh my goodness, we're going to talk about how that specifically shows up in diabetes. But yeah, and you can see as the fear and shame level changes and improves, people can move into action. And then the level of emotional self-efficacy. So this is really just saying, this is speaking to someone's comfort and ability to manage emotion in times of stress and distress. And this is really important as we were to keep in mind in regards to like nervous system regulation, how we were talking about, we really want to help our clients stay in that optimal zone of processing or optimal zone of arousal. And so emotion processing is a super critical tool for helping people stay in that window of tolerance. All right. So, resource scarcity greatly impacts the capacity for problem solving and executive functioning. This is, again, just speaking to that. Everyone's doing the best they can with the, emotional, physical capacity that they have at the time. So I know we've all seen these things, but I just want us to really, kind of drive home that I want us to keep this in mind. And if you're not familiar with Satter's hierarchy of food needs, this is based on Maslow's hierarchy of food needs, and it's on that same principle that, safety, consistency, consistent access to food. Like if we don't have that, we really can't be doing this higher level navigating diabetes and dosing insulin situation that we need to do. So part of what we're going to do to be able to understand the emotional fuel is using something that we will call the translator technique. So I love this tree. It's visual. It's beautiful. Huge shout out to Dr. LaFrance for creating this. I have a laminated version of this in my office that I bring out in sessions sometimes as we're talking about like, okay, what might be going on here? All of us have been in a situation where we're engaging in one of the behaviors at the top of the tree, right? I mean, we can think about, I'm sure that many of us have done at least one of these things at some point this week. So the idea is that the top of the tree are the behaviors that we display ourselves or that our clients display to us, right? This is what we're seeing in the room. This is what's presented to us. The top of the tree is what we're seeing. And what it's important for us to kind of think about is, okay, what are the roots, or what is the fuel? What's at the bottom of the tree? And these are the emotions that are most likely, or the big emotions that are most likely to be at the bottom. So fear, grief, helplessness, shame, self-blame, hopelessness. Those are the big ones that are fueling the behaviors at the top of the tree. And this is just kind of taking the tree and putting it in a little bit of a different format using that translator technique. So, you know, the idea is that in the room, we're seeing the things on the outer circle. So we might see over-compliance or under-compliance, hostility, defensiveness, criticism, anger, rejection, denial, or avoidance. And, you know, how we interpret what's happening, like when we, I mean, I don't know about you, but if someone approaches me with criticism, you know, or a little bit of hostility, I mean, what's your automatic reaction? You're like, whoa, like, oh my gosh, like, no, like, I'm not going to let, you know, we get defensive, we start to get hostile. And so the idea is that when we're seeing these overt behaviors in front of us, it's thinking, okay, like, let me remember what's the emotion underneath this. Because when we're thinking about the emotion fueling their behavior, it's going to drastically change our response. And, you know, if someone's approaching with hostility and defensiveness and we approach with that same, we match that, of course it's going to escalate, right? But if we can kind of have some compassion, it's not saying that we excuse it, right? Like, we're never going to excuse someone crossing boundaries for us, right? But it helps us, you know, be able to take a breath, take a step back, and respond with a bit more compassion and empathy. So the things that are fueling it, again, most likely it's fear, shame, helplessness, hopelessness in the healthcare space. These are the ones that are the most common. So stuck behavior in the patient reflects these unspoken processes. All right, and for anyone who works with families, this is actually just for families, or, you know, kind of the same thing, but with families in mind. So especially if you work with kids, oh my goodness, right? Like, we see all the time, maybe you have a mom who is struggling to set limits or boundaries, or maybe you have a mom or dad who's just like really overzealous and takes control, or is overprotective, enabling. I mean, there's lots of things that come up, right? And so a lot of times we want to go right in and kind of blame them, right? And be like, no, like, you are causing this, like, this is your fault. And if we can see, like, what is the loving and protective function of why they're displaying this behavior, it's really going to help us respond with a lot more compassion and also be able to help them a lot more, right? A parent who enables is a parent who is terrified. They are absolutely terrified that something very bad is going to happen, or that they're going to, if they push their kid too hard, then they'll push them over the edge. Maybe their mental health will get worse, or, I mean, there's so many things that could be underneath it, but a lot of times it's a lot of fear. And shame definitely comes in with families too, or parents, especially kiddos with diabetes, carry a heck of a lot of self-blame. So much self-blame. And so it's really putting ourselves in their shoes and thinking, oh, this is so hard. Like, they're carrying around so much burden. All right. And the reason why we want to tend to the emotions in the room, you know, we're not therapists. However, you know, this intervention that we're going to show you, it can take 60 to 90 seconds. It's super quick, and it is in service of helping someone when they're in emotional distress, right? We can't ignore that we are faced with emotion in the room every time we counsel someone. And the idea is that, you know, listening to emotion reduces stress on the body. So it actually takes people out of that fight or flight mode, which is common when they're in healthcare spaces, because a lot of people with diabetes are used to being blamed, or like they're coming in, like their threat response is activated when they're coming in, because they're like, oh, I'm going to be told that, you know, I didn't do this right and I didn't do this right. And, you know, there's a lot of fear. And so us being able to tend to that can actually help reduce the stress on the body, to bring the systems back to baseline. because feelings, they have to be felt, expressed, or heard in order to run their course. And if they don't, like here, this is what happens. So the idea is that the emotion gets stuck, and so then people can turn to maladaptive coping strategies to regulate. It says act out, but it's really just a maladaptive coping skill. It's like, I don't know what to do. Like, I have this emotion that's stuck. I don't know how to let it out. And so we turn to things like avoidance, denial, blame, like a million, all the things at the top of the tree, right? That's what happens when emotion is stuck. Okay, so how do we help our clients move through this? So I am going to teach you guys a skill called emotion coaching. It's just an advanced communication skill. That's all it is. And the idea is that we're going to help tend to these big emotions so that we can help them move through and then be open to receive the support that we want to give them. So in emotion coaching, a helpful visual is that emotion is like an elevator, and the door to reason, logic, and problem solving is on the ground floor. And emotion coaching is the way to get down to the ground floor. So what I always picture, and when I teach this to people, I'm like, okay, imagine like someone is at the top of the Eiffel Tower or the Empire State Building, right? Like they are like at the very top, like feeling very overwhelmed, very dysregulated, very threatened. And we've got to help them get all the way down to the lobby, to the ground floor, in order for any of our skills, like all these beautiful skills that we have as dietitians, right? To help them problem solve and move through the stages of change. Like those are all great tools, but we have to tend to the emotion first, because the door's not open to receive our problem solving if we haven't tended to the emotion first. So how it helps in the moment is, the idea is that there's some increased cooperation, avoidance of escalation. This is big, especially if you're faced with a client who's really quite upset. Then this is a beautiful technique to help avoid escalation. It can de-escalate. It can help someone regulate. And over time, it increases trust, self-confidence, and actually it increases their emotional self-efficacy. And honestly, it's helping you too. Like that's the beauty of co-regulation, is as you do this for others, you're actually benefiting as well. So the way this works is, if you imagine, so the limbic system is like the center at the back of the brain, like where to the right side of the bridge. And when someone is dysregulated, that emotional center of the brain, the limbic system is on fire. Okay. It is like, feels like there's an emergency. And when you're in the back of your brain, you do not have access to logic and reason, which is prefrontal cortex, right? So with emotion coaching, the idea is that each sentence of the emotion coaching is like a fire extinguisher on the limbic system. It's actually calming the brain down. It's putting the fire out. And then what it's also doing is it's building a bridge from the emotional center of the brain to the executive functioning part of the brain, which is the prefrontal cortex. All right, so the framework. So this is what it looks like. Emotion coaching is a two-step process. The first step is validation. And validation is conveying an understanding of their experience and proving that you get it from their view. Okay, so that is super important. It may not make sense to you, but it's kind of like, it's imagining, like an example that I like to give is, it's like, imagine that your client is in a deep, dark cave and you are crawling into the cave with them, and you're just sitting with them in the cave, and you're naming what it's like to be in the cave and what the cave looks like from their viewpoint. Then this next part, support. This is what we are culturally conditioned to do. We are not culturally conditioned to validate first in the way that I'm going to teach it, but we are culturally conditioned to provide emotional support and practical support, right? That is what we are so good at, and we don't want to change that. We want to still do that, do what we are so skilled at. We just want to add the step of validation first. Okay, so super important, what we want to establish first is, what is validation? Because there are actually so many different definitions. And so we're going to talk about what it is and what it isn't. So this comic kind of says, will you validate my parking? You did a great job, evenly spaced at nearly a perfect right angle. So, there's lots of different versions and definitions. So let me tell you definitely what it's not. So validation is not reassurance, which again, right? Like if somebody comes to you and says like, I can't, oh, we're actually going to do this, and Lauren, I'm going to have you help me with this. But so it's not reassurance. It's not problem solving, which let me tell you what, I'm an expert problem solver. I actually, it is a great skill of mine. I'm very proud of it. However, I can't do it first. I just can't do it first. Cheerleading, positive thoughts, like amazing. Like we do want to cheerlead our clients, just not first. So, okay, Lauren, we're going to call out, and if you're watching this, I want you to actually say out loud, what your response is to this, because let me tell you, everyone's culturally conditioned response is pretty darn similar. So, okay, Lauren. All right, I'm scared.
Don't be scared.
I'm mad.
Why are you mad?
I can't do this.
You totally can do this, Nikki. It's going to be fun.
Yep, that's totally what I would say. I don't want to do this.
You kind of have to.
Right.
I'm giving you the answers I know you want me to say right now, but
right. No, it's totally true.
I think it's also helpful to think about I think sometimes the way we talk to our clients is different than how we would say it if my sister said it to me. I'd be like, oh, you can totally do this, Jenna, you're fine. But if a client says it, we know to respond differently a little bit.
Totally. Yeah. And this is how everyone is conditioned to respond. And, I can say with clients, reassurance, problem solving, cheerleading. I do it all the time. It's my knee-jerk response because I do believe so deeply in my clients, right? I'm like, oh, I know you can do this, right? And they can. They just need here's the thing. If we do that first, what it does is it yanks people out of their emotional experience. Okay. It's like saying to them, oh, that cave you're in right now is too dark and it's too scary. And so I need to yank you out of there immediately because I don't want to be in there with you. That's icky. It feels wrong. And it is hard. But that's not what they need at the moment. They actually just need someone to be in the cave with them for just a minute. All right. So validation also is not, okay, so I'm going to say this, and I want you to think about which 3-letter words you're tempted to utter. So I can understand why you might not want to check your blood sugar. All right, what are you tempted to utter? All right, go for it.
Wait, do you want me to say it?
Oh, go for it. Yeah, or you can go to the next slide.
I didn't know what you wanted. Okay, cool.
Yeah, you can go to the next slide. Yeah, but, right, I can understand why you don't want to check your blood sugar, but this is important. Your safety, your life, it depends on it, right? That's totally a culturally conditioned response. We've all done it. We've all said it. And it's also unhelpful. All right, you can go to the next one. So in the core skill here is moving from but to because. Okay. So I can understand why you wouldn't want to check your blood sugar because. I can understand why you wouldn't want to come to your appointments anymore because you've had diabetes for several years now and you're probably really sick of all of the appointments, and because you really just want to break and want to be a normal kid, and because, you know, you should be at summer camp right now and you're missing out on summer camp because your blood sugars were too high for you to go this year. And that must feel really awful. So that's this can look, that's one example of how this can look, but it's basically, it's moving from but to because. It's naming the experience. So you can say, I can understand why you might feel, think, want. So it allows you to name an emotion or an experience, like what you're seeing, a behavior. So my examples were behaviors, right? Like, don't want to check your blood sugar, don't want to come to the appointment. And then the validation is in the becauses. Okay. So, and what's important is doing multiple becauses, specifically 3. So this has been studied, and they found that 3 were really helped to provide the most regulation. And also, if you only do 1 or 2, that's okay, right? Like, as you're practicing this, but just a general rule of thumb is 3 is great. And essentially, when the external environment, so what you're saying, when it mirrors their internal experience, the alarm bells they shrink, right? Like, they reduce, the alarm bells in the brain reduce in intensity. And now they're like, that elevator's on the ground floor. They're ready to listen and receive help. And something to think of too, the becauses, a couple of shortcuts. Like, if you go back to the beginning of our presentation and look at the psychosocial factors, like the emotional reasons why people get in burnout, there you go. Like, those are the becauses. That's what you can name. Another really great shortcut is the 3 H's, which is it's hard, it hurts, or it's heavy. But there's so many ways that you can say these. Go for it. So, okay, once you do the validation, then you go on to the support, the emotional support and practical support. And this is what you would have done anyways, okay? So emotional support is comfort, reassurance, togetherness, hope, that cheerleading. Practical support is whatever it is that you would have done as your medical nutrition therapy to help someone. All right. So here's just a written out example of emotion coaching burnout. So, and so the sentence starters, you can say, I can imagine, I can understand, or it makes sense. Those are all different ways you can start. But yeah, so it makes sense to me that you wouldn't want to check your blood sugar because you've been checking your blood sugar every day for the last 10 years. And because you feel a lot of shame when you see a number that you weren't expecting. And because right now it might feel too overwhelming to face that shame every day. And you just so badly want to break. And then the emotional support would look something like, I hear you and I believe in you and I know we can find a way to figure this out. How about we come up with the hierarchy of importance for checking blood sugar levels and start there? And I mean, the practical support could look so many different ways, and it's very much about who's sitting in front of you, right? And what you feel like using your clinical judgment would be a great way to go about it. All right. So just again, like the other visual, it's when you're doing the becauses, I just want you to envision that elevator is coming down and down and down. And similarly, your inflection will also start up higher and come down and down and down, right? Because this is the beauty of co-regulation. And so once you're down to the ground floor, the door is now open for support. And thank goodness, because if you go to the next slide, oh man, logic, reassurance, and redirection, sans validation. Well, just go on ahead and bang your head here. And we've all been there, right? Where we've been in a session and we're like, you know, it's like a tug of war with the patient, right? And you're like problem solving, you're like, you know, there's this like, and there's this, you know, it doesn't feel good, right? Like there's this tension, and it's likely because we've missed it. Like we've missed their emotional experience, and we went straight into problem solving too early. Right.
Yeah, I think as well, sometimes when we're missing it, it's like our own emotional response that's coming up as well. Like I'm concerned about this patient, or I'm scared for like their safety, or their like whatever medical complications are coming up are scary, or like even, frustration with ourselves. Like, oh, I should have said something different, or could have done something better to like better help them. Or, maybe if I had suggested this or done this, then like maybe their blood sugar would look different, or whatever it is. And so sometimes it's like focusing on our own emotional response, or getting caught up in that, rather than, focusing on like, well, what is actually like happening for the person in front of us, and like their emotional response to all of it.
Right. Absolutely. No doubt about that. And I do want to mention that we will provide a resource sheet for, like, if you want to dive deeper into emotion coaching. This was a very brief overview. Lauren just did a training with myself and like with Dr. LaFrance, and like there was a whole day on learning emotion coaching. So this was like, we just gave you a really quick overview, and we'll also give you some links to resources if you want to go deeper into it.
Yeah, absolutely. So we'll definitely pass that along if y'all have any other questions. I mean, I know we're doing a Q&A thing.
Yeah.
I don't know exactly what that's called, but Q&A thing. And so you can ask questions there, but always feel free to reach out to us. Nikki has a ton of resources, and there's a ton of additional trainings on EFFT, and if you're interested in that. But overall, Nikki and I are really passionate about working with people who have diabetes, and disordered eating shows up so frequently in there. And I think so much of the time that disordered behavior around food is, a way of coping with all of the distress and burnout that comes with diabetes. And so, we see a lot of this, and we work with this all the time. And so we'd be happy to answer any questions that y'all have about either like how to cope with it, or, maybe conceptualizing what's happening for your patients or your clients if you're seeing that and having a hard time understanding like what might be happening for them. So yeah, we're available.
Yeah. Thanks so much for listening and having us.
Yeah.
We hope you enjoyed today's presentation. Thank you to the presenters for doing a fabulous job.
Again, stay tuned for the Q&A. You'll see the link in the Facebook group on your emails, and you can find the recording later on YouTube.
Thanks again to our sponsors. Our gold level sponsors are Alsana, Center for Discovery, EDRD Pro, and Simple Practice.